You're going to have a patient on psych meds no matter where you work as a nurse. So you need to know what emergencies caused by psych meds actually look like. In today's podcast, you'll find out how to recognize EPS, neuroleptic malignant syndrome, serotonin syndrome, and an MAOI-related hypertensive crisis. But more than that, you'll find out how to prioritize what to do first so you can help your patient through it.
You were at the bedside doing your mid-morning rounds. At 0800, your patient was completely stable. I mean, they were sitting up in bed, drinking juice, chatting with you about their weekend plans. And then by 1100, everything has just completely derailed. Their temperature suddenly spiked to 103 degrees. They're sweating through their hospital gown. Their muscles are locked up so tightly you can barely bend their arm to check a manual blood pressure, and their heart rate is resting at 140.
Yeah, that is honestly one of the most terrifying clinical scenarios a nurse can face, mainly because of the sheer velocity of the deterioration. You are looking at a central nervous system in absolute crisis, and the bedside presentation is just completely overwhelming if you don't know the underlying patterns.
You are staring at a life-threatening psychiatric medication emergency. But the real question is, which one? So, welcome to this deep dive into Brooke Wallace's Super Nurse Clinical Notes. This is an installment of the Super Nurse podcast, created by Brooke Wallace.
Right, and we should mention Brooke is a 20-year ICU nurse, an organ transplant coordinator, clinical instructor, and a published author. She personally curates all this educational material and reviews every single deep dive for clinical accuracy.
Exactly. And to be totally clear, neither of us are Brooke Wallace. Right. We are just using this deep dive to build directly from her bedside knowledge, her clinical notes, and her teaching style. The whole mission here is to help nursing students and new nurses actually apply what they know to real-world patient care.
Yeah, to cut through the confusion between these really similar-looking psychiatric medication emergencies, because empowering you, the listener, to recognize these bedside patterns means you can take immediate concurrent emergency actions. And frankly, mixing up a common side effect with a deadly syndrome can literally cost a patient their life.
Before we jump into those patterns, I want to invite you to subscribe and definitely check out the comic book-based video on the Super Nurse Comics YouTube channel. The link is in the description. It's such a good visual tool. But getting back to the clinical side, before we can identify a full-blown life-threatening medication emergency, we have to understand the baseline adverse reactions a nurse might see, right?
Spot on. You have to know the baseline.
Okay, let's unpack this. Can you explain extrapyramidal symptoms, or EPS, in just plain language?
Yeah, absolutely. So EPS usually happens when we use dopamine receptor antagonists, right? Like your typical and atypical antipsychotics. We are basically disrupting the motor pathways, and Brooke's notes break EPS down into 4 distinct components. The first one is dystonia.
Which is like involuntary muscle contractions, right?
Exactly. Sustained involuntary contractions. So you walk in, and the patient might be locked into an abnormal posture, or you'll see these really uncomfortable twisting movements of their neck or torso. The second component is akathisia, and honestly, this one gets misunderstood a lot.
How so?
Well, it's this profound internal feeling of restlessness. It's not just anxiety. The patient is physically driven to move. They might be constantly pacing the halls, rocking back and forth, maybe even pulling at their lines because they literally cannot sit still.
Man, that sounds exhausting for the patient.
It really is. Then you have the third component, which is medication-induced Parkinsonism. This one visually mimics actual Parkinson's disease. So you're looking for things like resting tremors, a shuffling gait, and bradykinesia, which is just an overall slowness of movement.
Right, and then the fourth one is tardive dyskinesia. Yeah.
Yes, tardive dyskinesia. That involves repetitive involuntary movements, and it's really often localized to the face and jaw, so you'll see continuous lip smacking, tongue protrusion, or grimacing.
Okay, so EPS is clearly distressing, but it's generally more of a localized motor issue, not an immediate threat to life. Except there's one big exception in Brooke's notes, right?
Yeah, there's a massive exception. Acute laryngeal dystonia.
Because if that muscle contraction hits the vocal cords.
Exactly. You suddenly have an actively threatened airway. That is an absolute medical emergency requiring rapid intervention. But, and this is a crucial clinical rule from Brooke, we have to distinguish this from neuroleptic malignant syndrome, or NMS.
Right.
I need to make this absolutely clear. NMS is not simply severe EPS. It is not an EPS reaction that just progressed because someone missed it. They are entirely distinct clinical entities.
Okay, let me try an analogy here to see if I have this right. So is EPS kind of like a car with transmission issues? Like you have jerky movements, some restlessness, it's a rough ride, whereas NMS is just a total engine meltdown.
I love that analogy. Yes, that is exactly right.
So when exactly does that total engine meltdown occur? What does NMS actually look like at the bedside?
So building off that meltdown idea, NMS has a very classic warning pattern. First, you have recent exposure to a dopamine receptor antagonist or another supported trigger. Then you see dangerous hyperthermia, like the body's thermostat is completely broken.
Got a fever, got it.
Yeah. Plus severe generalized rigidity, often called lead pipe rigidity. Add in altered mental status and autonomic instability.
By autonomic instability, we're talking erratic vital signs, right? Wild blood pressure, high heart rate, sweating.
Exactly. But here's a really tricky part of the assessment. If a patient is completely rigid, you might expect their reflexes to be hyperactive. But NMS generally produces rigidity with normal or decreased reflexes.
Wait, decreased reflexes?
Yeah. And the specific correct term you need to use for decreased reflexes is hyporeflexia.
Hyperreflexia. Okay, we need to highlight that. So fever, rigid muscles, erratic vitals, and hyperreflexia. But what are the actual complications of all that muscle rigidity?
Well, when your muscles are locked up like that, they break down. That's rhabdomyolysis, which leads to an elevated creatine kinase, or CK level. And when those muscle cells burst, they can cause kidney injury. You can also see electrolyte abnormalities and dysrhythmias.
But just to clarify, based on the source material, we aren't saying every single patient develops all of those complications, right?
Right. Definitely not every patient, but the potential is there, and it's why NMS is so dangerous.
So what are the precise steps a nurse has to take when they spot this pattern?
So the key word here is concurrent. You don't do these sequentially, you do them at the same time. First, you recognize the concerning pattern. Concurrently, you withhold further doses of the suspected medication according to your facility's policy.
Which is an important distinction. The nurse is withholding the dose per policy in the moment, whereas the prescriber is the one who formally discontinues the medication entirely.
Spot on. It's an important scope of practice distinction. While you're withholding that dose, you also activate the emergency response and notify the appropriate provider. You assess and support the airway, breathing, and circulation.
The ABCs.
Always.
Always. You begin continuous monitoring, and you prepare for ordered laboratory testing and supportive treatment.
Let me play devil's advocate for a second. Shouldn't we just wait for the lab results, like maybe get those CK levels back to confirm it's actually NMS before calling the emergency response? I mean, we don't want to overreact. No, absolutely not. That is a critical rule. You never suggest delaying ABC support or emergency escalation while waiting for laboratory confirmation. NMS requires immediate action and urgent supportive care.
Okay, point taken. Treat the patient, not the labs. So what does that supportive care look like?
Well, the treatment, like cooling, fluid replacement, electrolyte management, and respiratory support, all of that must be individualized to the patient.
What about reversal agents, like antidotes?
So bromocriptine and dantrolene may be considered in selected severe or refractory cases, but, and this is vital, they must not be presented as universal antidotes. It's really about that immediate, individualized supportive care.
Got it. Okay, so NMS is severe rigidity and hypoflexia. But what if the patient is bouncing out of their skin and they actually have hyperactive reflexes?
Yeah.
Let's transition to a completely different neurotransmitter crisis.
Ah, yes. Serotonin syndrome, the neuromuscular overdrive.
Exactly. So serotonin syndrome results from excessive serotonergic activity, right? Like maybe they got a new medication, a dose increase, an overdose, or even a bad medication interaction.
Yeah. And the big thing here is the rapid onset. It usually happens very quickly. The bedside pattern includes altered mental status, autonomic instability, diaphoresis,
Sweating, yeah.
gastrointestinal symptoms, tremor, hyperreflexia, and Clonus.
Okay, we really need to clearly contrast this with NMS because they sound kind of similar if you're just skimming a chart.
They do, but they are very different. NMS is severe rigidity with normal or decreased reflexes. Hyperreflexia. Serotonin syndrome is neuromuscular hyperactivity, hyperreflexia, and Clonus. We absolutely cannot use terms like hyperreflexia, hyperthermia, and Clonus interchangeably.
Here's where it gets really interesting. So if I check a patient for ankle Clonus, and it's there, is that the single defining test for serotonin syndrome? Like, boom, diagnosed.
What's fascinating here is, no, it's not. Ankle Clonus is not the single defining test. Diagnosing this is about the whole picture. The medication exposure, the timing, the complete physical examination, and accepted diagnostic criteria all matter together. You can't just rely on one single reflex test.
Right, it's about seeing the entire clinical pattern. Okay, so we've covered crises involving dopamine blockers and excessive serotonin. But there's a third major emergency in Brooks' notes, and this one involves an enzyme, a specific medication class, and a really surprising trigger, their lunch.
Yeah, this one is wild. We're talking about an MAOI-associated hypertensive crisis.
So how does that work?
Well, MAOIs are monoamine oxidase inhibitors. They inhibit an enzyme called monoamine oxidase. Now, usually that enzyme breaks down tyramine, which is found in certain foods and drinks. But when the enzyme is inhibited, it can allow clinically significant tyramine exposure, and that produces a really dangerous hypertensive reaction.
So if I can try another analogy, monoamine oxidase is normally like the bouncer in our GI tract, keeping tyramine out of the bloodstream. But an MAOI sends that bouncer on break, letting tyramine flood the system and spike the blood pressure.
That is a brilliant way to look at it. Yes, the bouncer is gone, tyramine floods in, and the blood pressure skyrockets.
And what are the bedside warning signs for this? Because I imagine a sudden spike in blood pressure feels pretty awful.
It does. The warning signs are severe. You'll see a severe headache, which can radiate frontally, marked blood pressure elevation, obviously, palpitations, sweating, which is interesting because it can be hot and feverish or cold and clammy nausea, neck stiffness, or even chest symptoms.
Oh, wow. So it could easily look like a cardiac event if you don't know their med history. So patients on MAOIs just can't eat tyramine, right? Like zero-aged cheese or cured meats.
Well, this is where the big picture of patient education comes in. Tyramine restrictions actually vary by the specific MAOI.
Really? It's not just a blanket rule?
Nope. The source material gives a great specific example, EMSAM, which is a sledgeline patch. At the 6 milligram per 24-hour dose, it requires no dietary modification at all.
Wait, really? None?
None. But if that dose goes up to the 9 milligram or 12 milligram patches, then tyramine-rich foods and beverages absolutely must be avoided. So you have to know exactly what dose your patient is on to educate them properly.
That is a massive detail. Okay, so we have covered a lot of ground today. Let me just do a quick recap for you, the listener. First, we have to understand the baseline of EPS, those movement symptoms. Then we need to be able to spot the severe rigidity and hyperreflexia of NMS.
Right, and contrast that with the hyperreflexia and Clonus of serotonin syndrome.
Exactly. And finally, watch out for that tyramine-induced hypertensive crisis in patients taking MAOIs. And the golden rule for all of these, nursing actions in these emergencies are concurrent, and you never, ever delay ABC support while waiting for lab confirmations.
Definitely. And, I want to leave you with a final thought to just mull over. The textbook definitions of these syndromes are very clear-cut, right? We just laid them out. But in modern medicine, patients are frequently on really complex polypharmacy regimens. They're on medications that target multiple neurotransmitters at once.
Yeah, that happens all the time.
Right. So think about this. How do the nuances of your bedside assessment change when a patient's overlapping medications start to blur the lines between these classic toxicities? It's a real challenge at the bedside.
It really is. It takes a sharp, vigilant nurse to untangle that. Well, thank you so much for joining us on this deep dive. Remember to subscribe, and again, check out that Super Nurse Comics YouTube channel using the link in the description. See you next time.